hypercortisolism, Cushing's we did. Now we come to hyperaldosteronism. This is a group of conditions due to increased aldosterone secretion. It may be primary or secondary. You know that aldosterone is secreted from the adrenal medulla. Glucocorticoids, cortisol was secreted from the adrenal cortex. Now aldosterone is secreted from the adrenal medulla. Primary, it may be primary or secondary. Primary, you already know if the gland itself is not functioning properly, it is primary. If there is something other than the gland which is not functioning, then it is secondary. Primary hyperaldosteronism due to autonomous overproduction of aldosterone. Now, how is aldosterone regulated? It has no aldosterone, although it is secreted from the adrenal gland along with the cortisol, but aldosterone, the stimulation of aldosterone is due to the renin-angiotensin system. It is not, ACTH does not stimulate aldosterone. Right? So aldosterone control is with the renin-angiotensin system. So in primary hyperaldosteronism, there is autonomous overproduction of aldosterone with suppression of the renin-angiotensin system. If a lot of aldosterone is being produced, what will it do? It will suppress the renin-angiotensin system, which is the control system, and there will be decreased plasma renin activity. The most common manifestation is blood pressure elevation, right? Primary essential hypertension, you know that it is idiopathic, there is no cause for it. But whenever you have secondary hypertension, then the most common cause of secondary hypertension is hyperaldosteronism. The most common effect of hyperaldosteronism is due to what? There could be bilateral idiopathic hyperaldosteronism. The most common cause of primary hyperaldosteronism is bilateral idiopathic. No reason, just bilaterally both the glands start to secrete more aldosterone. It is characterized by bilateral nodular hyperplasia of the adrenal glands. The adrenal glands, both of the adrenal glands, they become nodular and they become hyperplastic and they start secreting lots of aldosterone. Patients are older with less severe hypertension than with neoplasm. Neoplasm, you know, wherever there is neoplasm, it has got much more symptoms as compared to normal hyperplasia. So here also, if there is neoplasm, then it is very high. The symptoms are very severe. But here, in hyperplasia, the symptoms are less severe. Then, secondly, it could be due to adrenocortical neoplasm. Commonly, an aldosterone-producing adenoma or rarely a carcinoma could be there. 35% of primary hyperaldosteronism is due to solitary aldosterone secreting adenoma, which is called Conn syndrome. So, many of the cases of primary hyperaldosteronism, there is a single adenoma secreting aldosterone, and this is called Conn syndrome. Third, uncommon cause is glucocorticoid remediable hyperaldosteronism. Secondary hyperaldosteronism, aldosterone, now we discussed this, when aldosterone, the adrenal medulla is over-functioning, it is primary hyperaldosteronism. When there is something other than the aldosterone, then it is secondary. Now here, what is the regulating mechanism? It is the renin-angiotensin system. So there is excessive, if there is excessive stimulation by the renin-angiotensin system, it becomes secondary hyperaldosteronism. It is characterized by increased levels of plasma renin. You measure the plasma renin activity and you find increased levels of renin activity. This can be due to decreased renal perfusion. If there is renal artery stenosis or there is nephrosclerosis of the arteries, then there can be the decreased renal perfusion, which can lead to stimulation of the renin-angiotensin system. Or there could be arterial hypovolemia and edema due to congestive cardiac failure, cirrhosis, nephrotic syndrome. There is hypovolemia, there is edema because of the renal perfusion is less and it causes stimulation of the renin-angiotensin system. Or in case of pregnancy, there is the estrogen causes increase in plasma renin substrate, and this causes increased secondary hyperaldosteronism. Clinical cause, the most important clinical feature is hypertension. If there is a young patient with hypertension, the most important cause is this. Primary hyperaldosteronism may be the most common cause of secondary hypertension. Aldosterone, now you know that what is the work of aldosterone. Aldosterone causes sodium retention by the kidneys, right? So when there is increased sodium, increased levels of aldosterone, they will cause increased sodium retention by the kidneys, and there is uh, salt retention. When salt is being retained by the body, it will retain water also, right? So it will cause increase of the ECF volume, increased cardiac output, and you know that increased cardiac output is a cause of hypertension, right? So this is how aldosterone causes hypertension. Long-term effects due to the cardiac compromise, increase in the hypervolemia, all the things causes cardiac compromise, increased prevalence of stroke and myocardial infarction. Now in this case, hypokalemia, previously we used to study that hypertension and hypokalemia. The thing which should come to mind first is hyperaldosteronism. Why hypokalemia? Because when the kidney it retains the sodium, it excretes the potassium in place of the sodium. So there is the loss of potassium causes hypokalemia. But nowadays we find that there are a lot of normokalemic patients also which in in the secondary hyperaldosteronism, many of them do not have hypokalemia. Probably because the potassium is coming out of the cells or something, because cells have a large amount of potassium. So probably the intracellular potassium comes out. But hypokalemia is now not a typical feature of this. The normokalemic patients can also be seen. Lab diagnosis, elevated levels of plasma aldosterone to plasma renin activity as a screening test. You measure the levels of aldosterone to the plasma renin activity. And confirmatory test, always when I told you in endocrinology, when you suspect a high level of hormone, you try to suppress it. So if it is suppressed, it is normal. If it cannot be suppressed, it is abnormal. So confirmatory aldosterone suppression test must be performed. Any query with this thing? Please ask me. If you have any question, unmute your phones, your computers, and ask me, or you can write on the chat. No. Now we come to Adrenogenital Syndromes. There are disorders of sexual differentiation. Example, virilization or feminization can be caused by primary gonadal disorders. If there's some disorder of the testes or the ovaries, then that is a different thing. But here, there can be adrenal disorder which can also cause virilization or feminization. Now, how? The adrenal cortex secretes two compounds, which is dehydroepiandrosterone and androstenedione. These are the two compounds that can be converted to testosterone in the peripheral tissue. These are the androgens. These are called adrenal androgens. And these adrenal androgens in the circulation, they are converted to testosterone, and testosterone can further be converted into estrogen. So, these are the compounds. How do they do it? ACTH regulates adrenal androgen formation. So we did that cortisol is stimulated by ACTH, but even the adrenal androgens are stimulated by ACTH. Aldosterone is stimulated by the renin-angiotensin system. So these two things are stimulated by ACTH. So if there is excessive ACTH, it can cause excessive androgen formation also. Adrenal causes of androgen excess include adrenocortical neoplasms and a group of disorders called congenital adrenal hyperplasia. Supposing there is adrenocortical neoplasm, it can cause androgen excess. Fine. Then there is something else which is called congenital adrenal hyperplasia. This is a group of disorders, right? Now what happens basically, this is the pathway how the different hormones are produced. Cholesterol, the first most important thing is cholesterol over here. We know or we think that we do not need cholesterol. We say that cholesterol is a bad substance, we don't need it, you should have less cholesterol. Yes, you should have less cholesterol. More cholesterol is bad, but cholesterol itself is necessary for our body. It is necessary to form these steroid hormones, estrogen, aldosterone, cortisol, aldosterone, and sex steroids, estrogen, testosterone. Then it is used for the formation of the cell membranes. It is used for the formation of vitamin D. So cholesterol, we do need a small amount of cholesterol in our body. But excess of cholesterol is bad. Now this cholesterol is converted to pregnenolone, and these are the different enzymes which are needed. The purple ones are the different enzymes in the different steps of the pathway. Cholesterol converts to pregnenolone, which converts to progesterone, and which this in the end produces aldosterone. This is one pathway, right? This is another pathway. Pregnenolone converts into 17-hydroxypregnenolone and goes down and forms cortisol. Thirdly, both of these, they go in this pathway, this way, and they form dehydroepiandrosterone, androstenedione. These are the adrenal androgens which later produce testosterone and estradiol, the estrogen. Okay. So this is the pathway which happens in a normal person. Sometimes what happens is any of these enzymes may be lacking. 21 hydroxylase, very important enzyme which is lacking. Supposing there is a person who does not have 21 alpha hydroxylase in his body. What will happen is, if you take an example of a road, take Sharai Faisal for example, lot of traffic moving on Sharai Faisal, right? And what will happen is, supposing all of a sudden there is a roadblock for some reason, road is being constructed or something is there, there's a roadblock. Now what will happen? The cars behind who are coming to that roadblock, there will be a rush of cars, full load of cars standing waiting behind the block, right? So similarly, this 21 hydroxylase, if there is not there, the progesterone is not converted to deoxycorticosterone. What will happen? Lot of progesterone, lot of pregnenolone will be accumulated, right? Behind the traffic jam, lot of cars. Behind the obstruction, traffic jam of cars. So lot of pregnenolone and progesterone are there, right? When lot of progesterone, lot of cars are there, now what will happen? The cars, they find a turn on the right, some cars will find a turning on the left, and they will disperse in other directions. They will not go in Sharai Faisal because they can't. So they will disperse in other directions wherever they find a place. So what will happen over here? If the pathway is not going in this direction, what will happen? These will accumulate and they will start going in this direction. Okay? So if they start going in this direction, they will form a lot of more. If aldosterone is not being produced, they will start producing a lot of cortisol, and they will go in this direction, and they will start producing a lot of androgens. Right? So behind the blockade, lot of rush, lot of compounds behind the blockade, and there is no path over here, so they will go in the other direction. Do you understand this? Any query with this? Anyone? Please, I want you to ask me questions. I get bored. No? Okay. So what is happening in congenital adrenal hyperplasia? There is a deficiency or a total lack of a particular enzyme involved in the synthesis of corticosteroids, especially cortisol. Now, any of these pathways, I told you, there can be either a deficiency, some enzyme is less, or there will be no enzyme. Then it can cause this disease. Hope there's a question. No? All right. Steroid precursors that build up behind the defective step. I told you there is a defective step, behind there will be a lot of rush. The build up results in increased production, are channeled into other pathways. They go into other pathways. They cannot come here. There is a block over here. They are steroid, the precursors are accumulated over here. They are channeled into the other pathways. In this pathway and in this pathway. Okay? Resulting in increased production of androgens, which causes virilization. Right? The deficiency of cortisol leads to increased secretion of ACTH, leading to adrenal hyperplasia. Supposing cortisol is not being produced, then what will happen? There will be decreased cortisol, which will stimulate ACTH. So now, supposing behind the roadblock, the cars are not going to the airport. Airport people say, why are the cars not coming? Please send more cars. So people from Metropole, they are sending more cars to on that Sharai Faisal road, and so more of a build-up behind the block, right? So there is increased ACTH because of lack of cortisol. If there is a lack of cortisol, there is increase of ACTH and leads to adrenal hyperplasia. So more cars keep on coming, and the roadblock becomes more and more. Certain enzyme defects may also inhibit aldosterone secretion, adding salt wasting to the virilization. Now, it depends on which enzyme is deficient. So sometimes there can be decreased cortisol, which will lead to increased ACTH. Sometimes there can be decreased Aldosterone, which can lead to salt wasting. Aldosterone causes salt reabsorption. So if aldosterone is not there, salt is wasted. Salt is wasted when there is hyponatremia. Right? Now, 21 hydroxylase deficiency. I showed you this enzyme 21 hydroxylase over here. This one is 21 hydroxylase. And there are three distinct syndromes in this 21 hydroxylase deficiency. It's the most common form of CAH, congenital adrenal hyperplasia. There can be salt wasting syndrome. There can be simple virilizing adrenogenital syndrome without salt wasting. The salt wasting is the most severe when there is almost no 21 hydroxylase present. When there is no 21 hydroxylase present, there is deficiency of aldosterone, there is deficiency of cortisol, both the things are there. If there is deficiency of aldosterone, so there is salt wasting. It's more severe. If the aldosterone is there, the other hormones are not being done, then there is simple virilizing adrenogenital syndrome without salt wasting. If there is no salt wasting, this is a milder form of the disease. No salt wasting, but there is virilization. And thirdly is the the least severe of it, which is there is a small amount of aldosterone being produced, the small amount of hormone enzyme being there. So because of which there is non-classic or late onset adrenogenitalism. This is salt wasting is found when the neonate, the baby is born, the enzyme is not there. So in the neonate, it causes salt wasting and then it can lead to death of the baby also. There is salt wasting, there is hyponatremia, hyperkalemia, acidosis, hypotension, cardiovascular collapse and death. Salt wasting. This one, not much causes, there is a virilization without salt wasting. Okay? And in the non-classic, this comes in the late, it may be asymptomatic. There is a small amount of this being produced, the hormones are there. So late onset and there is just some virilization. CAH should be suspected. I have not given you a lot of detail of this, but I have just told you the basics of these disorders. But one thing very important you should remember is that congenital adrenal hyperplasia should be suspected in any neonate with ambiguous genitalia. Any neonate which is produced, which has got ambiguous genitalia, you have to suspect for congenital adrenal hyperplasia. If by luck, by chance, there is less problem, then there will be no salt wasting, so then it is fine. It will just cause the virilization and the things. But if there is salt wasting in these babies, the neonate can die. So you have to be careful. Now we come to anyone who has not understood this. Can you ask me? Any problems with this? Congenital adrenal hyperplasia? No? Now we come to adrenocortical insufficiency, decreased secretion of the adrenal cortex. Can be primary, so you know that decreased secretion by the adrenal glands, or secondary due to decreased deficiency of ACTH. ACTH is not enough produced, less ACTH, so it causes decreased cortisol and causes secondary hypoadrenalism. Now, there can be primary acute adrenocortical insufficiency, which is called adrenal crisis. This adrenocortical insufficiency can be in three forms. Either it can be acute, which presents as an adrenal crisis, or there can be chronic primary chronic adrenocortical insufficiency, which is Addison disease, or there can be secondary adrenocortical insufficiency. Primary acute adrenocortical insufficiency occurs in a variety of settings. One, crisis, very important. Patient who has insufficiency, decreased adrenocortical hormones, and decreased hormones mean he is doing his work, whatever his things are there. But what happens, the patient, any form of stress which occurs in this patient, right? What will happen now? That the patient needs more steroids, but the glands are not working, so less steroid. Already the gland is producing less steroid, and the patient goes in any form of stress and needs more of the steroids. So, because he cannot get more of the steroids, he goes in a crisis. Okay? or patients who are maintained on exogenous steroids, taking steroids, they have maintained their exogenous steroids, whatever the steroid, the dose is maintained, but there is rapid withdrawal of steroids for some reason. You know that whenever you're taking steroid medication, you have to always taper the dose of steroid. So if there is a rapid withdrawal of steroids or failure to increase the steroid dose in response to acute stress, again, the patient is taking steroid, some acute stresses occurs, the patient does not take extra steroids which he needs. So that will go, the patient will go in an adrenal crisis. Or it can be due to a result of massive adrenal hemorrhage in the adrenal gland, which damages the adrenal cortex to cause acute adrenocortical insufficiency. This occurs in newborns following prolonged and difficult delivery with considerable trauma and hypoxia. So these are the cases in which primary acute adrenocortical insufficiency can occur. Adrenal crisis is a life-threatening disorder. Patients present with hypotension, hyponatremia, and hyperkalemia. Now, the symptoms of cortisol plus the symptoms of aldosterone decrease is also there, right? So there is hypotension, hyponatremia, and hyperkalemia. So if there is all these things, you should take this patient as having an acute adrenal problem unless proven otherwise. Three things if you see: hypotension, hyponatremia, hyperkalemia. First thing you should think of is an adrenal crisis because this is life-threatening. If it is proved that it is not adrenocortical insufficiency or adrenal crisis, then you look for other things. There can be vomiting, abdominal pain, vascular collapse, and coma. Death occurs rapidly until corticosteroid therapy begins immediately. You have to immediately give the patient corticosteroid, otherwise the patient can die. Now, primary chronic adrenocortical insufficiency called Addison's disease. It is an uncommon disorder resulting from progressive destruction of the adrenal cortex. Clinical manifestations do not appear until at least 90% of the adrenal cortex has been compromised. And when 90% of the adrenal cortex is gone, then the symptoms appear. It is one of the rare diseases. Addison's disease is considered to be a rare disease, but I personally know a person having Addison, so maybe it's not that rare. I don't know. More than 95% of cases of Addison's disease are due to one of four disorders. There are four main disorders which account for most of the cases of Addison's disease. They are tuberculosis, autoimmune adrenalitis, AIDS, or metastatic cancers. Now, in your book, they have written the most common cause of Addison's disease as autoimmune adrenalitis, right? And they have mentioned that autoimmune adrenalitis is the most common cause of Addison's disease in developed countries, right? In our country, which is a developing country, and in many of the developing countries, tuberculosis is still the most important cause of Addison's disease, most common and most important cause of Addison's disease. So in our country, it is still tuberculosis, which is the most important cause of Addison's, right? Most common cause of Addison in Pakistan, usually associated with active infection in other sites. Now, usually these people have active tuberculosis of the lung or genitourinary tract or any other site of the body. They have got active tuberculosis, and then it leads to adrenal infection. Autoimmune adrenalitis is the most common cause of primary adrenal insufficiency in developed countries. Okay, so if there is a question that in Pakistan, what is the most common cause of Addison disease? It is tuberculosis. In developed countries, what is the most common cause of Addison's disease is autoimmune, right? There is autoimmune destruction of the steroidogenic cells. Certain cells, autoantibodies against 21 hydroxylase, against 17 hydroxylase, these are the enzymes which we discuss in the whole chart. There is antibodies to those enzymes have been found in these patients. It can occur in one of two clinical settings. One is Autoimmune Polyendocrine Syndrome type 1. This is called APS1. There is Autoimmune Polyendocrine Syndrome type 2, APS2. In APS1, the patient has chronic mucocutaneous candidiasis, candida, fungal infection of the skin, mucocutaneous, abnormalities of the skin, dental enamel and nails. There is ectodermal dystrophy, and a combination of organ-specific autoimmune disorders like autoimmune adrenalitis, autoimmune hypoparathyroidism, idiopathic hypogonadism, or pernicious anemia. So in APS1, there is mucocutaneous candidiasis, there is adrenalitis, adrenal hoga is ID hypoparathyroidism, hypogonadism, pernicious anemia. Right? And because of all these autoantibodies, there is destruction of the target organs. In APS type 2, there is adrenal insufficiency along with autoimmune thyroiditis or type 1 diabetes. AIDS sufferers are at increased risk for developing adrenal insufficiency from several infections like cytomegalovirus, mycobacterium avium intracellular, and non-infectious like Kaposi's sarcoma complications. Metastatic neoplasms. Now, patients who have got disseminated carcinoma, tumors of any organ, and they are disseminated, one of the common sites of dissemination is the adrenal. So, mainly carcinoma of the lung and breast, but many disseminated cancers also can metastasize to the adrenals, causing adrenal insufficiency. Also, there can be genetic causes of adrenal insufficiency. The clinical cause, the disease begins insidiously and does not come to attention until the levels of circulating glucocorticoids and mineralocorticoids are significantly decreased. Slow progression of the disease is insidious in nature. Okay. There can be progressive weakness, easy fatigability, GIT disturbances, anorexia, nausea, vomiting, weight loss, diarrhea. In primary adrenal disease, there is hyperpigmentation of the skin. Why? We discussed this, that primary adrenal disease means that the adrenal is not functioning, it is not secreting the cortisol. Because of decreased secretion of cortisol, the ACTH is stimulated. When the ACTH is stimulated, large amount of ACTH being produced. When large amount of ACTH is being produced, the precursor of ACTH is POMC, pro-opiomelanocortin. Large amount, the cortisol causes stimulation, the lack of cortisol causes stimulation of POMC, which causes increased secretion of ACTH, and it also causes increased secretion of melanocyte stimulating hormone. We discussed this when we discussed the pituitary gland, right? So, decreased cortisol stimulates the pituitary, which causes increased secretion of POMC, increased secretion of ACTH, and increased secretion of melanocyte stimulating hormone. When there is increased secretion of melanocyte stimulating hormone, lot of melanin is being produced, and because of increased melanin formation, there is hyperpigmentation of the skin. Where does it occur? In the sun exposed areas and pressure points. In the neck, elbows, knees, and knuckles is quite characteristic. The elbows, the knees, the knuckles, and the neck. Okay, so this is because of ACTH. So you must remember that any condition in which the ACTH is increased, there will be pigmentation. Cushing's also, if it is due to ACTH increase, it will cause a pigmentation. Addison's also causing ACTH increase, it will cause pigmentation. If ACTH is not increased, there will be no pigmentation. Very important, you have to remember this. So, hyperpigmentation is not seen in patients with adrenocortical insufficiency caused by pituitary or hypothalamic disease. If there is a pituitary or hypothalamic disease, there is less ACTH already. So, if there is less ACTH, there is no hyperpigmentation. Decreased mineralocorticoid activity results in potassium retention and sodium loss. We discussed this. Aldosterone causes sodium excretion, potassium retention. So, hyperkalemia, hyponatremia. Stresses such as infections, trauma, or surgical procedures in these patients can precipitate an acute adrenal crisis. Now, this patient is on Addison's disease. They are taking the normal amount of steroid. Yeah, but if there is some infection, there is trauma, there is surgical procedure, there is some stress, it can precipitate an acute adrenal crisis. So the patient has to take, you have to give the patient more steroid at this time. Death may occur if corticosteroid therapy is not given immediately, if there is acute crisis. Lab findings in case of Addison's disease, there is hyperkalemia, hyponatremia, volume depletion, hypotension, ठीक है, hyponatremia, hyperkalemia, aldosterone, again because of the loss of water, there is the loss of sodium, there is loss of water, loss of water, loss of sodium, decrease ECF and hypotension, ठीक है. Hypoglycemia may occur as a result of glucocorticoid deficiency and impaired gluconeogenesis. We discussed in Cushing's. Cushing causes hyperglycemia, so in lack of cortisol causes hypoglycemia. Secondary adrenocortical insufficiency. Now, adrenal is all right, but there is something other than the adrenal. So here again, the adrenal is stimulated by the cortisol. Decreased cortisol stimulates the ACTH. So, if supposing if there is secondary adrenocortical insufficiency, means there is some problem in the pituitary or the hypothalamus. Like metastatic cancer, infections, infarctions, or irradiations that reduce ACTH leads to a syndrome of hypoadrenalism that has many similarities with Addison's disease. The symptoms are almost the same, but that you find out that there is decrease of ACTH causing the decrease of cortisol. With secondary disease, the hyperpigmentation is lacking because levels of MSH are not elevated. Must remember this, that secondary disease, ACTH is less, hyperpigmentation is not there. There is a deficient cortisol and androgen output, but normal or near normal aldosterone synthesis. Now, why? Because ACTH stimulates cortisol. ACTH does not stimulate the aldosterone. So aldosterone will be normal or near normal, but ACTH stimulates cortisol and the androgens. Both the other steps of the pathway are stimulated by cortisol. Aldosterone is stimulated by the renin-angiotensin system. So if there is decrease of ACTH, it will cause decreased cortisol, decreased androgens, but normal or near normal aldosterone. Thus, in adrenal insufficiency secondary to pituitary malfunction, marked hyponatremia and hyperkalemia are not seen. There may be slight amount of this because slight amount of aldosterone may also be less, but marked hyperaldosteronism and hyperkalemia, hyponatremia and hyperkalemia are not seen because there is aldosterone is almost normal. Okay, laboratory evaluation. Plasma ACTH and cortisol levels should be tested in the early morning around 8 AM. I told you this, that in Cushing's, when you are suspecting high cortisol, you test the cortisol in the late night, or the three first time tests which I discussed with you, always on the late night, because you want the lowest levels of cortisol. But here, when you are suspecting low cortisol, you try to take the cortisol in the peak of cortisol levels. So peak of cortisol, peak of ACTH is usually in the early morning around 8 AM. So when you suspecting Addison's, the blood test should always be taken around 8 AM. Many times we get in our lab also, we get the request for cortisol, the patient is coming at 12 noon, patient is coming at 4 PM. It's useless to take cortisol at this time, to test for cortisol at this time. You should do it. Cortisol is always tested in the early morning or the late. Low plasma cortisol associated with a high plasma ACTH is characteristic of primary Addison's disease. Primary Addison disease means the adrenal gland is not producing cortisol, so there will be low cortisol. Because of the low cortisol, it will stimulate the pituitary and there will be high ACTH. So low cortisol with high ACTH is primary Addison's disease. In secondary disease, there will be low ACTH and low cortisol. Secondary pituitary is not working, ACTH is less, so cortisol is less, right? Then there is a test to stimulate when you are this, again we did this, that we are suspecting low levels of cortisol, we try to stimulate it. In Cushing's, what were we doing? We are suspecting high cortisol, we are trying to depress it by giving dexamethasone. Here we are thinking that there is low cortisol, we try to stimulate it. How do we stimulate it? By an ACTH stimulation test, or this is called a Synacthen test. What you do is, what is Synacthen basically? A Synacthen is synthetic ACTH, which you get injectable form, you get it in the pharmacy. And what you do is you stimulate the adrenals by giving the injection of Synacthen. What is blood sample is taken for baseline cortisol levels. First you take the blood sample baseline, call the patient at 8 AM in the morning, take a baseline cortisol sample, then you administer synthetic ACTH or Synacthen is injected into the body, and you take the blood for cortisol after half hour and after 1 hour. We perform this test in our lab. So what you find is, in a normal person, giving added ACTH, what will happen? The cortisol will increase. Okay? 30-minute value being greater than the 60-minute value. There is a rapid increase in cortisol in 30 minutes. It's a normal person, you and me. Then there is a nil response. That means even if you give the ACTH, there is not much increase in cortisol. So this is characteristic of primary Addison's disease. Why? Because the gland is unresponsive. Whatever, how much cortisol you give it, the gland will not work because it's dead, dying, whatever, it's injured, it's not working. When the gland is not working, however much ACTH you give, there will be no response. Right? This is a nil response. That is a indication of primary Addison's disease. Then there is something which is called a sluggish response. That means slight increase in cortisol, 60-minute value greater than the 30-minute value. That means there is a slow response. After 60 minutes, there is a response, and there is not that much of an increase like a normal person. So this is suggestive of a secondary adrenal dysfunction. That means if the pituitary is not functioning properly, you give ACTH and you give a better response. So this is secondary adrenal insufficiency. Any problem, any query with this? Please ask me. No? Okay. Multiple endocrine neoplasia, MEN syndromes. These are a group of inherited disorders resulting in proliferative lesions. Hyperplasia, adenoma and carcinomas of multiple endocrine organs. So many endocrine organs have got the proliferative lesions, and many endocrine organs are hypersecreting and they produce this syndrome. Occurs at a younger age, arises in multiple endocrine organs. Even in one organ, the tumors are multifocal. Preceded by asymptomatic hyperplasia, usually more aggressive. Okay? MEN type 1 is also called Werner's syndrome. In this, there are 3 P's. P, parathyroid, pancreas, pituitary. 3 P's are there. MEN type 1, Werner's syndrome, you remember pituitary, parathyroid, pancreas. 3 P's are there. Okay? MEN2, there are 3 types of MEN2. One is MEN2A, in which there is pheochromocytoma, medullary carcinoma of the thyroid, and parathyroid hyperplasia. These 3 glands are excessively working. Pheochromocytoma, medullary carcinoma of the thyroid, parathyroid hyperplasia. This is MEN2A. MEN2B is similar to MEN2A but without the hyperparathyroidism. Same as 2A, but there is no hyperparathyroidism. And the third one, familial medullary thyroid cancer. It is a type of 2A, but there is just medullary carcinoma of the thyroid. These other things are not there, just medullary carcinoma of the thyroid is there. So this is the third one.